A very good morning to all of you. We start the first session, first day, first session. The instruction course is on Back to the Surface, new look at advanced surface ablations. So the first topic is epithelium removal options in advanced surface ablations. I will start with the first talk, and I have my co-instructors with me, Dr. Aniket Shastri, who will be talking on two-step PRK versus trans PRK. And we have Dr. Nitin Balkrishnan, who will be joining us in 5 minutes now, who will talk on newer modalities to manage complications or sequelae of ASA. And we also have a keynote address by Dr. Jan-Pierre Rosenbaum. He will talk on trans PRK 18 months experiences with 2 excimer lasers, Schwind SmartSurf and Alcon Streamlight. So we'll start with the first topic by me, that is epithelium removal options in advanced surface ablations. Hello, Nitin. No, they called me. But then Anand said he's one and a half hours. Nitin, there's enough time. There's enough time. Let her present. So laser vision corrections have come a long way from 1973. Started off with PRK, which was approved by the FDA in 1995, and LASIK was approved in 1996. And surface ablations continue to evolve. From the 1980s, when it was called the PRK, with no mitomycin was used, it was minimally invasive, but there was a lot of pain, there was haze, there were regressions, and hence came LASIK. With fast recovery, pain was almost nil just for a few hours, but there were problems like flap complications, ectasias, flap-induced aberrations, thin corneas could not be treated. And of course, the cost and the maintenance of the microkeratomes. Now, Dr. Nitin Balkrishnan, who is also a co-instructor here with me, is one of, I can say, my guru who taught me PRK, LASIK, and I remember the times when we were breaking our heads with the microkeratomes not going forward, backward, all these problems that we used to have, the maintenance issues, and of course the cost of the blades. So we came back to the surface with a variety of procedures, that is PRK with mitomycin C. The mitomycin C helped in reducing the haze. There was also the LASIK, that is epithelium is loosened with the help of alcohol, and epi-LASIK, where a microkeratome was used. Epi-LASIK, of course, is not really done today because the flaps were very thin. There were a lot of flap wrinkles, flap complications with epi-LASIK, and hence it was not something that we could do. So now in alcohol assisted, this is where the alcohol is used, and it is of course diluted. We use the corneal trephine, which is about 9 millimeters, keep it there for some time, and then the epithelium just comes off. The Merosol sponge is used, which is dry, so that it helps in removal of the epithelium like this. So this was the one of the methods that we started doing PRKs and surface ablations with. One of the problems with this was if the alcohol leaked, then there was a problem with the stem cells at the limbus. The other procedure which came in was the Amoyles brush. This is the brush which rotates and revolves and helps in the removal of the epithelium. And you can make out that the epithelium is off because it gives that particular dry surface that you can see on the cornea. And that's how we knew that the epithelium was off. This was the Amoyles brush, which did away with the alcohol and its problems. The other very innovative and a very good procedure now is trans PRK, which the excimer laser itself removes the epithelium, and then once the epithelium is removed, about 60 microns of the epithelium is removed, and then the laser is done and the mitomycin is used. So this is how the trans PRK is done. And of course, with any surface ablation, you need to put a contact lens because the epithelium is off, and we need to make sure that it heals. So the contact lens nowadays we place at least for about a week so that there is a proper healing. And it has been seen that normally the epithelium would heal in 2 to 3 days. But if you remove the contact lens earlier, it can cause a little bit of haze and things like that. A newer method is EBK, which is Epi-Bowmans Keratectomy, which is an equipment like this, and it helps in removing the epithelium as well as the Bowmans, and in a very smooth manner. So this is one of the new techniques which has come in. Of course, I don't have any experience with it, but there have been studies which have shown that the Epi-Bowmans blunt keratectomy was compared with the epithelium removal of with the help of alcohol, and it was seen that this technique may minimize the post-operative pain, accelerate re-epithelialization, and offer earlier visual recovery compared with the alcohol removal. And this was one of the studies which was published in the Cornea Journal in 2019. So the advantages of advanced surface ablations are: it is safe in borderline corneas, there is no effect on the posterior segment, there is less thinning because you have more of a residual bed, there is less dry eye, and the retreatments over the LASIK flap are also possible, and it can be combined with a corneal cross-linking. So these are some of the ways in which we are able to remove the corneal epithelium, and like I said, now it's the Epi-Bowmans which has come in. So all these removal of epithelium per se is where the evolution of surface ablations is going, and there are newer and better methods coming up time and again. So the evolution of the surface treatments, as you can see, PRK was FDA approved in 95. It was seen that there was epithelial injury causing post-operative pain, late visual recovery, and of course the risk of haze. And that's why came in LASIK, which was approved in 1999. Intrastromal incisions, the LASIK caused intrastromal incisions into a deeper plane in the stroma, causing a risk of corneal ectasias. It was unpredictable sometimes, and flap-induced aberrations were there. And that's why we came back to the surface with advanced surface ablations. Thank you very much. I now call upon Dr. Aniket Shastri. If there are any questions, we'll be happy to. It is six. Well, it is the machine itself which does it, and it removes 60 microns of the epithelium. But one of the methods probably would be if you had, in the machine itself, if you had incorporated the pachymetry. In case we don't have that, then we are, having done so many surface ablations, we are just hoping that, and even if a little more is removed, I don't think it really matters, because we are still above when we are removing with the help of excimer, we are ablating the cornea, so we are still above as far as the ASAs go.
Ideally, we would like to do an anterior segment OCT and get the thickness of the epithelium and feed that particular data in this thing. That's one way out. The second thing is, if the anterior segment OCT, the epithelial thickness is different in different areas, you're not sure, it's better to err on the higher side. In the sense, suppose it shows you a 55 in one reading and a 60 in the other reading. It's better to err on the side of 60, because a 5 micron more ablation, even if considering the 55 was right and you're ablating 60, a 5 micron more ablation will not give you a refractive surprise of of more than 0.25 diopters. So it would be better to feed the higher reading than the lower reading. Thing number 3 is, in case you do not have a method of you do not have access to a anterior segment OCT, when you're doing a PTK, this is not for trans PRK, when you're doing a PTK followed by a PRK, Dr. Aniket Shastri will be talking about it, there is a change in the color. If you see the beam, the excimer beam, when it hits the cornea, moment the epithelium is removed and once it goes to the stroma, there is a change in the color which is noticed immediately. So
yeah,
this is a person
removing the epithelium, it's a
bluish color. That's right.
You see.
So a change in the color. This is an observation. This is not a very exact method, but this is for those cases where you do not have an access to a anterior segment OCT.
There's a new software also. There's a new software also. Just like how the topography is adjusted onto the machine that does the LASIK. Similarly, you have nowadays a software that calculates how much is our exact epithelium, just like how an AIOC2020 epithelium does. And the same thing along with the topographer, the epithelial mapping is also done, and accordingly the software adjusts how much of the epithelium is to be removed and how much of the stroma is to be treated according to the refractive error.
So we go on to the next speaker. I call upon Dr. Aniket Shastri.
Thank you, ma'am. Yeah, I'll be speaking on something commonly termed as a trans PRK. Now there was a brief introduction given by Dr. Shilpa Kodkany, and yeah, basically around in the 1980s and early 90s, we had the surface ablation to treat our refractive errors, and because of the problem with pain and haze and the emergence of LASIK, what happened was it almost disappeared in the mid-90s. And then with the problems of LASIK and some of the changes that occurred in the pharmacological and the machine status and our better understanding of the cornea, it again resurfaced in the 2000s. We all know that the main limitations of PRK still remain then also. It was basically pain, healing and haze, and the introduction of mitomycin C was basically revolutionary when it came to trans PRK. These are some of the recent advances that have been there on surface ablation, the change in the machine, better understanding of the procedure, the pharmacological modifications, and the biomechanics that we have understood so that we can prevent ectasias. Of course, as I told you, mitomycin C has revolutionized the procedure and results. This is something which Madam has already discussed. One of the key areas which we tried to improve the pain and epithelium healing was basically the way we removed the epithelium. Either it was manual or it was alcohol assisted, where when we took out most of the epithelium and then did the laser. Then we tried to do something called as LASEC, where we tried to preserve the epithelium, and just because it sounded like LASIK, probably tried to impress the people there. And then here we preserved the epithelium, and then after the main trans-PRK PRK project was torn back. Then this is using a microkeratome. We tried to remove the epithelium, and which was put back after the laser procedure. And all the control studies shows mixed results with these techniques, with no definite proof that one is better than the conventional. This is what came up as trans-epithelial PRK, where they used a PTK mode to take out the epithelium, followed by the photorefractive keratectomy. There was no instrument that was in contact with the eye, reduced intervention time, of course, and because the epithelial size can be matched with the stromal ablation, they were similar. And we were avoiding alcohol because of the transfer. But one thing which everyone has to remember is trans-epithelial PRK is not trans-PRK. Trans-PRK is a totally different software. Trans-epithelial PRK, whenever you try to go into your search data, you put trans-epithelial PRK, if you go through the study, it will tell you it is PTK followed by trans-epithelial PRK, and the results of trans-epithelial PRK, that is PTK followed by PRK, compared to other manual, were not so great. In fact, there was a delayed epithelium healing. And the problem was that when we applied laser, centrally it was quite perpendicular to the cornea, and what was later assumed was probably hypothesized was when the laser hits the periphery, it is hitting at an angle. So the laser has to travel more. If it has to travel more, then as the time goes by, it hits at an angle, energy is less. So the epithelium that is removed at the periphery is not as smooth as it is removed in the center. So there can be some amount of energy discrepancies between the center and the periphery, leading to uneven epithelial removal and subsequent irregular healing. This is what is trans-PRK. It's an all-surface laser ablation. It came in 2009-2010, where it differs from the previously described trans-epithelial in a number of aspects, where the custom epithelial profile here has been generated from the population studies, which have demonstrated that the epithelium is usually not uniform thickness. The ablation profile that is generated from this population model, it actually targets 55 microns centrally and around 65 microns in the periphery. And for an 8 millimeter, this is for an 8 millimeter ablation zone, with further consideration for differential ablation in the epithelium. So here the epithelium is not ablated using a common PTK profile, but a differential epithelial profile. And it is not carried out as two distinct steps. It's not that you apply PTK, go to the machine, change over to the PRK, and again apply a PRK. Here it's a single step. Once you press the pedal right from the beginning till the end within a minute, it is a continuous procedure. So the risk of dehydration is less. And one thing this software does it applies the stromal component of the ablation first. Then that is followed by the epithelial component. Now what happens is, if you apply the epithelial component, then apply the stromal component, irregular stromal healing, the epithelium covers up and it's not a smooth, the irregularity is maintained. When you do the stromal component first, then the epithelium component, what it does is it tries to smoothen it out. So this is what the population studies were where 70% of the population had a central pachy of 55. And the epithelium part that is removed is refractive neutral. It neither causes a myopic or an hyperopic shift. And the pulse rate to remove the epithelium is on a higher compared to the refractive pulse rate. So the damage is less. And the ablation volume for the epithelial removal is slightly significantly higher, so that even if there is some slight discrepancies between the population and the patient lying on the table, it can still cover up most of the things. So this is what is the experience we have with is our Schwein Damaris. It's a 500 Hz excimer laser. So this is what happens in trans-PRK. It treat the surface by, it superimposes an aspheric ablation profile, actually with a defined epithelial thickness profile. That's on the literature values and the mean epithelial profiles. And this trans PRK, this is combined, and this is the spherocylindrical profile, and this applies on the epithelial thickness profile that is quite thinner in the center than in the periphery. And because the laser is applied directly on the epithelium, and it is calculated according to the epithelial profile and the laser is adjusted, the stromal bed is pretty smooth. And in regular corneas, it provides quite a safe, efficacious and reliable results. So when it comes to irregular corneas, what happens is, that is when the stromal ablation happens first. The profile of the stromal ablation is put first, and after the stromal ablation, the epithelial ablation comes in. Just the profile is different, the effect is the same. The effect is the same, the refractive error which you are treating is the same. So finally what happens is, the irregularity that is expected because of irregular healing of the epithelium is solved. This is the same thing which I was trying to say. So this is what the Schwein-Damaris profile says. Once you, this is on the screen that comes before treatment, it gives you the value that you are supposed to treat, how much it is treating, what is the profile, what is the residual stromal thickness, what is the ablation zone, total zone. So this is what it is. It just shows that it is a trans PRK mode. It's not a PTK followed by PRK mode. And second thing is, there is no epithelial removal stage in this. It goes directly to the treatment stage. So once cyclotorsion is checked for any kind of any cylinder more than 0.75 diopters, either plus or minus, then the treatment starts here. You see once, and it also shows you how much time is remaining. If you see in the left corner, it is hardly 41 seconds. 41 seconds is the total treatment time for the whole thing. And once it starts, it's a single step where it is applying both the ablation profiles, one after the other. There's no break in between. And the whole 41 seconds is done continuously. And then you apply mitomycin C, and the rest of the procedure is same. So this is what one of the studies tried to find out, that at day 3 the pain score was statistically significantly lower, in fact, in the surface this trans PRK group than in the usual manual PRK group. At the end of 1 month, it all becomes the same. In fact, it's at the 1 week or the first few days that matters. The postoperative corneal haze also at the end of 1 month was same. It was statistically significantly better in compared in the trans PRK group. At the end of 1 year, either the haze or the epithelial or the refractive profile was not different. But at the first beginning stages, that is when the transepithelial, the PRK used to cause the pain and healing problems. That is what is better. And because the epithelium is healed fast, epithelium is healed better, the profile is smooth. Obviously, the early part of the procedure, the vision is better. This improvement, in fact, of the PRK comes at no cost to the outcomes. The outcome is same. We have been doing excellent results with it. And this was, in fact, superior to the conventional alcohol-assisted PRKs. And with reference to safety also, it was pretty safe compared to, because we are not using alcohol and any other methods. There's another new profile which is added to the trans PRK, which will be dealt by the adjacent, the rest of the speakers, which is called smart pulse or smart surface, where the ablation profile is not as a flat 3D surface cornea, but it takes like a ablation profile of a football structure. It's just equivalent to the football structure, just like of the small dots, the two football planes are added to stitched together. So it can be compared to a surface of a soccer ball with equidistant intersections. And this profile is added. And you can see the difference, the smoothness that is there, it's homogeneous, that's on the right. The smart plus technology, or the smart laser technology, is still got a better, shorter recovery time, higher level of post-operative visual acuity, reepithelialization time is faster, and low pain in surface ablations. Thank you.
Thank you, Dr. Aniket Shastri. Any questions? Dr. Aniket?
Yeah. Yes, sir. Sir, if you ask me, the procedure of choice for low myopes, say somewhere in the range of -1.5, -2, 2.5, I would go for trans-PRK. Okay. And if it is slightly higher, which is somewhere in the range of -5, -6, that is why we advise at our center to go for a femtolasic. Okay. Because even though we have done even for -5, -6, -7 also trans-PRK, the only thing is the pain and the recovery is slightly more there because the ablation is more. Okay, but because the epithelial profile, especially with the newer technology of smart pulse that we have, that has been introduced recently, the epithelial healing is in fact very fast. If you try to do, I mean, we have not done it, but the studies have shown that if you try to within a day or 2.5 to 3 days is when the epithelium heals off. We just keep the BCL for a longer time because the epithelium is still loose and you don't want the patient to be rubbing around.
Thank you, Dr. Aniket. Now, I call upon Dr. Nitin Balkrishnan to tell us about the new modalities to manage complications and sequelae of ASA.
Good morning, everyone. The reason why PRK, or advanced surface ablation as we call today, has, or in between, had lost its real charm was that there were a few bugbears. The main important bugbears or complications of an advanced surface ablation was pain, haze, which we all had to face when we started our PRK careers, and regression. Regression, again, as per clinical data, has been seen that it's higher in cases where there is haze. So basically, it's linked to the haze. The causes for haze are also somehow or the other interlinked with the causes for regression. Now let's come to the first bugbear, that is pain. In cases of any surface procedure, it's very important that a good counseling be done. Because unless a good counseling has been done, a patient is not going to be aware that there is a chance of having severe pain, unlike in a case of a LASIK. So patients usually compare a colleague of theirs or a relative of theirs who undergone LASIK, and they feel that even their procedure will be the similar one. So one has to be very clear and explain to the patient right at the beginning. So the good counseling, and while doing the counseling, it is important to assess the psychological profile of this patient and do a good personality assessment. If the patient is a hypersensitive type or hypersensitive to pain, this patient should be in fact counseled better. And if one feels that it's a type A personality who would not tolerate pain, it is better that a surface ablation is not done on this patient instead of doing a surface ablation and then having a problem. Anxiolytic drugs have been used to decrease the anxiety and to solve any of these problems of pain. It's usually started pre-operatively and continued for almost about a week post-operatively. During the procedure, chilled BSS before and after ablation helps in decreasing the pain. Topical NSAIDs like ketorolac are used. Ketorolac soaked bandage soft contact lens. This is a new modality which is used. I'll speak about it in the next slide. Topical prednisolone. Instead of using a soft steroid like fluoromethalone or loteprednol, in these cases, a prednisolone would act much better as compared to a soft steroid. It helps in decreasing the pain. Oral NSAIDs like diclofenac, and in severe cases, gabapentin has also been used. That is almost 300 milligrams given pre-operatively and then 300 milligrams thrice a day for 3 days after the procedure. Diluted proparacaine have been used by certain people, but I would want to caution the house that judicious use of this is very important, because this can hamper the epithelial healing and the patients can continue using this over a prolonged period of time even after you stop it, and this is where the problem then comes up. Ketorolac soaked contact lenses. This is a research presentation of Narayan Netralaya in Bangalore. Dr. Rohit Shetty and his team had presented this, where the surface of a bandaged off contact lens is initially cleaned with an antiseptic solution. 0.2 ml of AccuVeil, that is a preservative-free ketorolac, is then injected into the blister pack of the contact lens, and it is allowed to soak for 20 minutes. This contact lens is then used as a depot ketorolac on the cornea after doing the ablation. So this helps, and they found that the results with the AccuVeil soaked contact lens to decrease pain is much better as compared to giving topical ketorolac. Let's now come to the second bugbear, that is haze. Let's understand what drives haze. It's a common fact that haze is driven by either inflammatory factors, which could be a preoperative existing inflammation, or an inflammation which comes after the procedure, due to the ablation. There could be also some other causes of haze, which we will now talk about. Now, preoperative inflammatory factors could be a poor ocular surface, history of contact lens intolerance. Patients who are intolerant to contact lenses before coming in for a refractive procedure, one has to be very careful, because there is a reason why the patient is intolerant to contact lenses. There must be an inflammatory factor which has to be initially checked out. Meibomian gland disorder, this is a very, very important point which if not treated initially can give rise to a severe amount of haze. Ocular allergies, low vitamin D levels. So first and the foremost, let's come to the ocular surface. OSDI scores in all patients undergoing advanced ASA is very, very important. Schirmer's test as well as a tear film breakup time. In cases of poor ocular surface, it's very important that preoperatively the patient is started on a lubricant, topical cyclosporin if the Schirmer scores are very low, topical soft steroids preoperatively. Let's now come to the Meibomian gland disorder. This can be diagnosed either on a slit lamp or on an autorefractometer with the infrared light. So either you can check out for cap glands or Meibomian glands dropouts, or one can use advanced mammography techniques in which you can not only find out the gland dropouts but also quantify them. Now, pre-op management of Meibomian gland disorder is very important, and this can be in the form of warm compresses, lid massage, and in severe cases a gland expression. If this doesn't help in real severe pre-op drugs like oral doxycycline, topical azithromycin, lubricants can also be used. If this doesn't help, then one can think of either a light modulation, which helps in cases of preoperative Meibomian gland disorder, or a thermal pulsation to express the Meibomian glands. Ocular allergies like papillary conjunctivitis can be picked up initially and should be picked up, and one can also consider getting an MMP level of these patients checked. Raised MMP levels in these patients should caution one that this is a type of patient who can go in for a haze. IgE levels, if it's above 250 international units, one needs to take an immunologist's opinion before taking up this patient for PRK. Patch tests to detect allergies are also important. Now, preoperatively, one needs to treat all the ocular allergies, either with topical antihistaminics, olopatadine, alcaftadine, bipotastine, topical steroids, which needs to be continued for 8 weeks post-operatively in case the patient had a pre-existing allergy. Topical cyclosporin continue for almost 12 weeks following PRK in cases of pre-existing ocular allergies, and topical tacrolimus can also be used. We all know that vitamin D influences the corneal wound healing. So any preoperative vitamin D less than 10 milligrams per ml, one should go in for an injectable depot dose of 6 lakh units. And between 10 to 30 milligrams, one should consider 8 weeks of either oral or spray or sublingual vitamin D. Let's now come to the intraoperative factors which affect haze. The first and the foremost intraoperative factor is the epithelial removal. Trans PRK generally gives rise to a smoother and uniform epithelial removal, as Dr. Aniket has elucidated, and this leads to a lesser haze than mechanical removal. Again, in mechanical removal, it's very important to note that cases where the epithelium is loose and easy to remove, these are the cases where there is more haze, and therefore in these cases steroids should be given for a longer time along with cyclosporin. Whereas in cases where the epithelium is tight and difficult to remove, the haze produced is less. This is an observation which has been done, and This is quite true in most of the cases. Again, so in cases of tough epithelial removal, you can give steroids for a shorter time along with cyclosporin. It's also been found that the angulation of the spatula, which you use to remove the mechanically debride the epithelium, also decides the amount of haze. So if you're using a 90 degrees angulation of spatula, the haze is much more because of increased activated keratocytes, increased fibroblasts and aberrant collagen, as compared to a 45 degrees angulation of the spatula. So what is the medical management? The medical management for these cases is post-ablation mitomycin C 0.02%. Usually we use 10 seconds per diopter treated. Post-operative steroids, instead of using a soft steroids, in these cases one would try to use either dexamethasone or prednisolone, continue for 8 weeks following the procedure. Post-operative cyclosporin for as long as 12 weeks. And at least for 2 months, the patient should be instructed strictly not to expose his eye to UV radiation. So UV protective glasses for 12 weeks following the procedure. So in conclusion, a thorough pre-op assessment, treatment of all the factors influencing pain and haze pre-operatively, meticulous intra-op planning and management, and strict post-op treatment protocol will help us reduce the complications of haze, pain, and the consequent regression which occurs with trans-PRK. Thank you.
Any questions?
No, these are the cases where there is a preoperative risk factor for developing haze. In these cases, we try to use dexamethasone for a longer period of time. But otherwise also, the using either prednisolone or dexamethasone for about a month, if not 2 months, is the chances of haze are much lesser than stopping it early and shifting to a soft steroid. Yeah, that's true. Right. AccuVale, you will need to tell your friendly Allergan representative. The company, it's not available commercially today, but the medical representatives can get you the AccuVale, the samples. So,
Have you used it, Nitin?
I have used you mean the I use Ketorolac in all my cases for the first week or so.
No, I mean.
You're talking of
in
bandage
the-
contact lens? Yes, I have used almost about 8 or 10 patients. I've used AccuVale soak bandage contact
So
lens.
do
Risk
you
with
find
with using surface NSAIDs is they have a potential tendency for corneal melting.
Melting also.
So you have to be very,
So
very
you have to
careful
be, you have to
about
be,
that.
it has to be a judicious use.
So do you find that the pain is drastically reduced with it?
With the
with
bandage soft
AccuVale,
contact
yeah.
lens soaked in AccuVale, yes,
Yeah.
101%. The pain is much lesser.
Okay. Thank you, Dr. Nitin. I now call upon Dr. Sujata Mohan from, she's the director of Rajan Eye Care, Chennai. She will give us some pearls on ASA, some advanced techniques like Topo guided treatments. So on to Dr. Sujata Mohan.
It's not come here. Thank you, Dr. Shilpa. At the outset, I'd like to thank you for including me in this course. So this morning I got a message saying go to Hall C. My name was nowhere here. So, but anyway, she said you come over and give your talk. So this is. So I just had to quickly prepare a talk on surface ablation pearls. It's not coming on here. Excuse me. Yeah, thank you. If I'm stepping on other people's toes, I'm not very sure about it because I just prepared it very quickly. So just to go about a little bit of history about surface ablation, Theo Seiler was the first to perform a PRK in 1987. And this was the first LASIK or alcohol-assisted PRK was performed by Dimitri Asar in 1996. And then came the laser-assisted subepithelial keratectomy, which was popularized by Camlin. And then the advanced surface ablation and the use of Amoy's brush and the transepithelial PRK that we are doing today. So indications are thin corneas, patients with topography suspect, prior LASIK complications. If the patients had a flap complication earlier, it's better to do a PRK. Patients with irregular astigmatism, glaucoma suspects, because then you know, or patients with a family history of glaucoma, because you're very sure that if you are having a glaucoma, checking the post-op after LASIK is going to be very difficult, so doing a PRK would make sense. Patients with recurrent corneal erosions, because they will benefit by it. Epithelial basement membrane disease, patients with dry eye syndrome, or too flat or too steep keratometry if you don't want to do a femto. And it's a very good alternative to LASIK, provided you follow all the protocols. So in my case, if there is a thin cornea of less than 500 microns, immediately I would jump to do a surface ablation. And I would always insist on a calculated residual stroma of less than 300 microns, whether the maps are normal, even if the maps are normal. So let's take a case of 2 diopter of myopia, which is low myopia with a low Pachy and normal maps. It's 480 microns. It would be safe to do a surface ablation in this procedure, because the amount of tissue that you remove will be about 25 microns, and your residual will definitely be much better than if you do a LASIK. The next, this is again a second case where you have 12 diopters of myopia, but all the parameters are normal. But again, the patient has a very low Pachy. 477 has got a very good anterior chamber depth. So this case would be ideal for a phakic IOL implantation. The third case is a topographic suspect. Again, you can see that the keratometry appears normal, and the surface looks pretty normal. But if you look very closely, you can see there is a little bit of skewing of the axis. And again, as a pointer, there is the Pachy is low. I'm sorry, I don't have some good pictures because it was all put in the last minute. But you also have to look at the posterior elevation, because this is what I have noticed, because in some patients, the keratoconus starts from the back side. And you will be surprised they'll have an absolutely normal surface, but the posterior elevation changes will be significant. So any patient undergoing refractive surgery, posterior elevation should be looked into. So in low myopia with suspicious map, 1 out of 4, anterior and posterior elevation normal, surface ablation can be done, but if there is posterior elevation change, it's better to avoid it. So also prior complications of LASIK, like what you have a free clap on one side, or a buttonhole, or an epithelial ingrowth, it's better to avoid doing a LASIK and go in for a surface ablation. This can also be combined in patients who have developed some amount of power after implanting a phakic IOL, or have a residual power. You can combine and do a surface ablation. So other planned indications are high myopia up to -8 diopters, glaucoma suspects. If the patient is a sportsman and there's an increased risk of injury, then you can this could be another indication. And I think all the other indications I've already spoken about. And the recent years, we are doing a topo-guided PRK, in which we use a surface ablation to normalize the cornea. So this is how the map looks in a surface ablation. You can see that there is an inferior cone. And what this laser does is, it ablates the inferior portion, and also creates a hyperopic profile. So basically, it normalizes the central cornea. So this is a topo-guided PRK, which is done in patients with keratoconus. The depth of ablation normally should not extend more than 30-40 microns, and again depends upon the amount of abrasion the patient has. So this has to be, there's a software with all the laser machines available now, and this can again use for surface ablation. So this is one of my patients who has a 5.5 and it's dropped down to 1.25. You can see there is some amount of normalization in this difference map. So contraindications are unstable refractive error, very high myopia, high hyperopia, astigmatism, and keratoconus or pellucid marginal degeneration. Autoimmune disease, surface problems like a patient has recurrent HSV keratitis, collagen muscular disease, uncontrolled glaucoma, diabetes, pregnancy, and lactation. And in patients with surface ablation who are afraid of the pain or have severe dry eye, better to avoid this. I think Nitin has already covered all these things. The advantages is a very low learning curve. So if you're starting with laser, it's best to go with the surface ablation. So I think this has been covered very nicely by, you have covered the pain and management of Haze also, no? Nitin? Okay. So I think with that, I will come to the end of my talk. So I think you have to have a appropriate management selection of patients Give adequate mitomycin C, frequent follow-up, ask the patient not to get exposed to direct sunlight. That's one of the things I learned. And the results are fabulous. And so patients who cannot afford a femtoLASIK or thin corneas can definitely undergo this procedure. Thank you.
Yeah.
Sujata, what is the thinnest you would go pachymetry wise and for doing a PRK?
470, not more than that. Anything less than that, then I suspect in the back of my mind probably the patient is going in for a keratoconus. Even if it's a PRK, because I have seen a lot of people say, no, you're going to do only 2 diopters, and what's going to happen? I don't know, I may be just waking up a sleeping tiger, so which I don't want to do.
And
Yes.
For the benefit of the house, in case you have a 480 cornea, how many diopters would you safely correct? In the sense, would you see a percentage surface ablation?
I normally prefer
or
not to
residual
do,
stromal?
I normally prefer to do not more than 6 diopters in surface ablation, because what I find is the amount of haze is very dense. How much ever you use a mitomycin C, I may go up to -8. I have done 15. I'm not that I have not done. All these years I've done so many problems, but now I feel, no, when there is a very viable this thing as phakic IOL, where if the patient is fit, I think that should be what it is done. And also you have to look at the keratometry. You cannot have a keratometry of 42 and correct 15 diopters. So you will be making the cornea totally flat, making it so oblate, the quality of vision will go down. So all those things also have to be taken into consideration, not only the corneal thickness and pachymetry.
Dr. Sujata,
Yes, sir.
Yes, so you have a question?
Yeah, please, please.
what would you do for cases between 6 and 8 diopters?
I mean, it's a difficult decision to make. I would definitely discuss with the patient. I would look at the keratometry. Suppose the keratometry is 46 or 47, then I would definitely not hesitate doing PRK, surface PRK. But I would tell the patient, if you want more stability, I would definitely go for a phakic IOL. Depending upon the other factors as well, you know, the EC depth and the specular microscopy and all that, I would definitely lean towards a phakic IOL than towards laser. Just because it is laser, it doesn't mean it doesn't have its problems.
No, what I mean to ask you is, instead of a surface ablation, would you go and do a femtoLASIK?
Yeah, absolutely. If the femto is possible, I would definitely, after the first choice would be femto. Between the last two. Yes, sir. Yeah.
Yeah.
PRK would be better, sir, because PRK would be a better choice, because if you cut the flap, you're not altering the surface. Because the surface, there is either it is something like a partial buttonhole where only the epithelium has been lifted and the Bowman's membrane is remaining. And that is what happens, you know, sometimes because the loss of suction, this happens. So in that case, you can go ahead and do a you can do a PRK. Because the PRK results will be very good, where you're actually treating the problem. And you can do a contour, this. Yeah. Yeah, but even if once you remove the epithelium and you expose the Bowman's, so that will give you a better control than making a flap again, because it's an irregular treatment. A part of it you have done it on Bowman's and part of it you have done it on the stroma. So you can't, again, if you lift it, you're not going to have a very clear surface. You can use contura. You can use a topo-guided PRK for virgin eyes, not for keratoconus. No, there might be haze. So these patients, particularly post-PRK, post-IOL implantation, post-LASIK, they are more prone for haze. So you have to use mitomycin C at least for 2 minutes and put them on low-dose steroids for a long time. That is... I have had a similar case like that, sir. That's how I handled it. I had a thin layer of epithelium, just exposing only the Bowmans. I think they do well. Yes. Surface ablation, the problem is haze. Absolutely agreed. So you have to use mitomycin for a longer time. There are reports where they've used it even for 3 minutes. I don't exceed 2 minutes, but in these patients, definitely 2 minutes. 2 minutes. Yes. Yes, sir.
One thing I want to add, that in case, not exactly the post-treatment, but during treatment, many of the times what happens is if you don't get a proper flap, if you feel the flap is not good, the flap is not there, and especially at places where where the software has a trans-PRK, best is not to lift the flap. Change over the software to directly to a trans-PRK, and you can directly apply the trans-PRK, a single step, same sitting, same, don't lift the flap. If you lift the flap, that is where the trouble starts. If you feel there is a doubt, don't lift the flap, directly apply trans-PRK. It will just act just like a trans-PRK, nothing else. This, we have faced these issues and we have seen good results with it. Thank you.
Cornea is a very forgiving surface, and that's why we get away with most of our problems. Thank you.
Sujata. Yeah. I invite Dr. Jan Pierre Rosenbaum for the keynote address on refractive laser trans-PRK, 18 months experiences with 2 excimer lasers, Schwind SmartSurf and Alcon Streamlight. Welcome, sir.
Yes, thank you very much for your invitation. It's a pleasure for me to be with you in India. I was in August in India, and I love this country, and it's a pleasure for me to be here with you today. And so I'm going to speak about the experience I have on trans-PRK, which was a new entity 18 months ago. And at the beginning of my this work, I worked with 2 lasers, Amaris Schwind and Alcon WaveLight. And so we have about 18 months of experience about that. So the first question was, what is interesting in TPRK when we compare it with PRK? What are benefits? What are the benefits? Is there benefit in comparison with PRK, which gives very good results? Epithelium manual debridement is very simple, so why to use laser? Are there clinical advantages? Is it only marketing? Are we sure that Excimer has completely removed epithelium? Is there specific software programs on PRK? It's the first question we ask ourselves before beginning this procedure. Is it useful? Classical PRK is a good technique. We know it, and we know this technique since a very long time. There are advantages and disadvantages. The disadvantages is, of course, postoperative pain during 1 to 3 days, progressive visual recovery, sometimes haze, retreatment sometimes difficult, and we have to wait long time before retreatment. The advantages are simplicity, precision, and we have less biomechanic weakening and low risk of ectasia. You have spoken about Haze origin. It appears between the first and the 3rd month post-operator and causes refractive regression. The causes are by epithelium hyperplasia, by increase of refraction index, by refringent corpuscles in keratocyte, and by disorganization of extracellular collagen matrix. It is favorized by cells apoptosis, which induce neocollagen 3 and atypical synthesis of glycosaminum glycan. It's favorized, of course, by thermal rise and by ablation over 100 micron, and also by the ablative slope. It's favorized by low healing and by infection. What are the three main advantages of TPRK? First, we have accelerated healing and visual recovery. By limiting ablation to what is strictly necessary, by smooth surface. We have less pain by accelerated healing and limitation of desepithelialization surface. We reduce the risk of Haze by acceleration of healing, by smooth surface and gradual slope, by removing the damaged cells, by controlling the thermal rise of the cornea with laser delivery algorithm adapted specially to TPRK. Yes, TPRK is a new entity. We have specific pre-operative exams to do, and the corneal OCT mapping is very important to have an exact evaluation of the epithelial thickness. Also, there are specific algorithms for this laser, almost on the Schwind. And these algorithms take in account the heat emission, because we need more laser shoot to treat epithelium plus stroma. We can have hyperopic and myopic shift related to beam spread in the peripheral. And there is also a difference in photoablation efficacy between stroma and epithelium, corneal epithelium. The Amaris propose a treatment in one time, a very long experience from Amaris, and Streamlight Alcon recommends a treatment in 2 times. Here you can see the corneal mapping, and it's integrated to the TPRK treatment. Everybody knows that epithelium is thinner in the center. What we have to consider is a volume, because with laser we are going to treat epithelium plus stroma, and this equals a volume, and a total volume equals a number of shots for myopia and for hyperopia. What are the consequences of evaluation error? When we have myopia, the risk, the more risk is if we have under evaluation. If we are over evaluation, we have no many risk. The same for hyperopia. So what we have to know, it's if we have the choice, if we have to do the choice, it's better to over evaluate it than to under evaluate the epithelium, corneal epithelium. What are the technological features of the two lasers, Amaris and WaveLight? Amaris has algorithm very sophisticated. This permits to have a thermal elevation control, and this permits to treat in one phase. The laser I use work at 750 Hertz, but we will have only one shot every 25 milliseconds on the same point. This limits the elevation of thermal elevation on the cornea 34 to 40 degrees. It's very important to control the temperature, thermal elevation, if we want to avoid haze. If we compare with WaveLight, we have 2 phases. This laser work at 500 Hertz, but we will have one shot every 10 milliseconds. We have more thermal elevation, is the reason why we need 2 phases with a pause between the 2 phases. On the Amaris, we have a vertex centration on WaveLight pupil centration. On Schwinn, we have active cyclotorsion. In WaveLight, we have passive cyclotorsion. There are no royalties by procedure on Amaris, and we have in France royalties for each procedure on Alcon. The photoablation features is different for the two lasers. In Amaris, as you have seen in the other communication, the profile will begin by the refractive profile, and after we will ablate the volume corresponding to the epithelium, and is different for the WaveLight. WaveLight will begin by epithelium ablation, like PTK. Then we do a pause, and after we treat refraction. We have to program in Schwinn Amaris the vertex epithelium thickness, and we will have ablation increased by 10 micron in peripheral. And in WaveLight, we will program the maximum value of mapping we find on the pre-op mapping. My protocol. I do refractive since very long time, and I never used mitomycin. I think it's always surprising, but I'm one of the surgeons who never use mitomycin, even in TPRK. And I've no any Haze, but when I think that people are used with mitomycin, and they are afraid that if they don't use mitomycin, then they will have a Haze. So what is very important in this procedure, TPRK, is eye serum to control, to have a temperature control, because we have more laser spot to avoid laser. I let a contact lens during 5 days. If we want to avoid Haze, we have to, hydration is very important. I use personally ipromelose every hours with contact lens during 5 days. Then during 4 times a day during 15 days. Antibiotics is very important, because if we want to avoid Haze, we have to avoid infection. So personally, I use tobramycin and norfloxacin 4 times a day during 8 days. And also, I use dexamethasone drops 3 times a day during the 5 days after operation. But I never use mitomycin. The visual recovery, acquisitive recovery, and post-op pain in PRK. The pain is shorter in TPRK than in PRK. Maximum is in between 6 and 9 hours, then the pain decreases. At day 1, foreign body sensation during 24 hours. Day 2, we will have epithelium healing about 50%. Day 3, healing 75%. Day 4, healing 100% and visual recovery 70%. And at day 5, we remove a contact lens, and we have a visual recovery about 90%. We treat myopia between 1 to 8 dioptries with very, very good results. The same for hyperopia, to 0 to 3 dioptries. And also I treat LASIK, retreatment of LASIK 10 years after LASIK or 15 years after LASIK is very interesting to treat with TPRK, because we avoid the risk of epithelial invasion, and we have very good results. We can see the results with this case. In this case, we have a treatment of -7, very good recovery, very good topography, and very good epithelium mapping a few weeks after. The same for this treatment, -1.75 with small astigmatism, with very good recovery. We can see, this is a 6 months post-op on this patient operated by hyperopia plus 390 minus 1, and we can see there is not any haze. If we observe, we can see a small haze in the periphery, and it's corresponding to the slope of the beginning, but it's perfect. And to finish, you have seen a film, and I'm going to. It's very easy to treat this with this laser. It's a Schwind. And so the centering is very. In fact, we have to take care at the beginning of the treatment of the tears, because we have to go because we have a laser recovering, laser ablation. So we have to go very fast at the beginning of operation to avoid to have dry eye. And so in the same time we begin very quickly to obtain homogeneity on the surface. And after, it's very easy. Operation will take about 1 minute, and it's finished. And not any problem. And this laser, I'm very satisfied with the Schwind laser because it's very quick, it's very easy, and we have very good centration and not any problem. Thank you very much.
Lovely talk, sir. So your choice would be Schwind. Schwind, your choice of machine would be Schwind.
Yes, I began with Alcon, but I think now it's very, I consider that it's a new entity. It's not very difficult, of course, to treat with TPRK, but there are some elements we have to take care. I don't put betadine inside the eye to don't modify the tears, to have homogeneity of the tear. And so we have to go very fast to avoid to have dry eye, because if before treatment the eye is dry, we can have modification of the surface. So what is very important is don't forget to put ice serum. And what I think also is very important is hydration. We have to put a lot of drops after TPRK to avoid the haze. I think it's the main important.
I just have a small comment regarding the haze. I think probably in Caucasian eyes, the incidence of haze is very less. But in Indian eyes, even when we do a PK, it is every suture that you pass, you can see a streak of keloid formation. So the haze in Asian eyes is much more, and if we don't use mitomycin C, every single case, whether we are doing -2 or -10, will have haze. Yeah. So I think comparatively, we also have more sun and more UV light. And so definitely the incidence of haze is much more in Asian eyes. I don't have any papers to support it, but we do see them universally in all corneal procedures. Mm-hmm. Even if you suture, I have visited some of the European countries, and they have done PK. You can hardly make out that ring. You cannot see anything. But here you can see so clearly, because I think the haze formation is much more in our eyes.
I was when I was a student, I began with the first laser PRK, and so I know all the first lasers, and I saw the difference between in Haze generation, you see, and so around all the colleagues use mitomycins, of course, and I'm alone to don't use mitomycin, and people are afraid to don't use mitomycin. Personally, I think that what is important is to obtain quick healing, and hydration is very, very important, and no infection. And personally, when I showed to people who come to see me, I've no haze, not any haze, but I begin a study to demonstrate that after a few years, I know not any haze.
What is the maximum diopter you correct, sir?
I limit in TPRK. In TPRK, I go now to about in myopia 8 dioptries and Epi-Bowmans 3.5. And also, it's very interested when we observe patient operated by LASIK, perhaps 10 years ago or 12 years ago, and in Epi-Bowmans or in myopia, and retreatment is very, very easy to do. And you know, if we have to have retreatment on LASIK by BPRK to treat Epi-Bowmans, in 3 days, patients are well.
Yeah,
And
that's another, I think, one important point that you said, which we have to emphasize, is doing an anterior segment OCT to find out the epithelial mapping, particularly when you're going to treat a haze or you're going to treat a recurrence, that is a retreatment if you're planning. So, and if you're using something like Streamlight, then also it helps to do an ASOCT, to do an epithelial mapping and find out how much of epithelium you're going to ablate. Because in some patients, they just have 50, in some of them, they have 55. And so if you don't correct it, then you will be left with an undercorrection. Thank you, sir.
thank you.
A question, Jean. A question here. Jean, what is eye serum exactly? And
Excuse me.
eye serum.
Autologous serum.
What exactly is
It's
it?
an autologous serum?
Eye serum is BSS.
Oh, it's not an autologous serum, which is.
Serum.
BSS.
Old
BSS.
What is
it's very cool. It's very eye serum.
Okay. Cold BSS.
Eye serum is like lubricating drops, or is it autologous serum?
It's a drops. I put drops. Just if you want to see.
And my other question was, does everyone in France also not use mitomycin C, or is it your personal choice?
No, in France, people, as you do, use mitomycin.
Okay.
And but I'm beginning a publication to show that we don't need mitomycin, and but everybody prefer to use mitomycin. It's why I give this precision.
Right.
Yeah.
Yes.
So I think the take-home message is that we still use mitomycin.
Especially for Indian eyes.
Yeah. Any more questions? I think we have 5 minutes more.
The one more use of this PRK now is, like I said, retreatments. It's become very simple after using Streamlight, because you really don't have to worry about the flap getting dislodged, because if you're doing a manual removal, then the chance that you may remove the epithelium or the flap interface. So this becomes very, very easy, and it's safer also. We also know that safer because we are not, we may not be inducing ectasia. So that is a great advantage of doing this Streamlight, where once you have done the ASOCT and you can go ahead with the retreatment.
The other advantage of the Streamlight was, like Aniket mentioned, especially when you're doing a femto LASIK and you see that due to some reason there's been a break in the vacuum while the femto is passing and the side cuts are not proper, or you feel that the flap, do not lift the flap, wait for the OBL to clear and do a Streamlight. It works really well, because these are the cases where you not lifted the flap and the flap has not got dislodged.
So there are several ways of managing a haze. One is you can just remove the epithelium and go inside and scrape the haze. Sometimes it just peels off, and then you probably may not even need to do a correction. So this I have done for a very dense haze, but you have to warn the patient that you may not be correcting it fully, so unless you are very sure about it. So the first step would be to remove the epithelium and use a 15 blade to completely scrape off the haze, apply mitomycin C for about 2 minutes, and then allow the epithelium to grow back. And in this patient, from -6 regression, he came to -1, and he opted not to go for a retreatment. So there are instances like that in which if the haze is very dense, you can do it. But if the haze is an ASOCT, if you see that the haze is very thin, and then there is a minor regression, then you can go ahead and do a TPRK, remove the epithelium and everything in one go and go ahead and correct the laser. So the actual idea is to do an ASOCT and see how thick the haze is.
True.
The thicker the haze, the fibrosis, the more likelihood you can just scrape it off. But mitomycin C has to be applied for all these patients.
Would you do a PTK instead of just scraping with the knife for getting, once you remove the epithelium?
No, in this, because this was before we started the Streamlight, so I did peel it off. I just used a 15-degree blade to peel it off. Now I think probably you can do it, but the question is how far deep you will go. So I would probably do again a manual procedure just to see how it's peeling off. But if it is very irregular, surface is very irregular, then you can use a PTK mode and smoothen it a little bit. So the best thing would be not to get a haze. So if you see a haze developing, pump up the steroids. 100%. That's why you have to follow up these patients quite closely, especially if you're doing higher treatments. And you see haze developing, increase the steroids. And watch them very closely. Usually if you increase the steroids, it regresses. The type of honeycomb haze that we see, which appears in about 2-3 months and then settles by itself, is nothing to worry about. What I'm talking about is a dense haze, which might cause a regression.
And like I said, 8 out of 10 times there are some, if you go back and check, there are some pre-operative risk factors which had been missed in these cases of dense haze.
Very often it is the MGD, where we see a haze later, and then sometimes we see later on that yes, there was some amount of MGD which probably got missed.
Yes, sir. Generally, I use, if the haze is the first few days, if the haze is very dense, I start them on lotipred for about a month. And then after they switch over to softer steroids like FML, I'll keep them for 3 months, totally 3 months. Once a day for last 1 month. So taper down very quickly, but keep them on once a day FML for 1 month. Once a day, yeah.
In cases of PRK for a hypometric patient, I would see what is the treatment, the ablation zone, and based on the ablation zone, then we have to decide this thing. In case it's depending on the optical zone, the ablation zone would vary. So if I would go for 0.2 millimeters beyond the ablation zone.
So normally it will be around 9 millimeters, sir. Because
so
you get an 8.9 if you keep the 6 millimeter zone, then about 8.9. But now with Streamlight, everything is integrated. You don't have to worry about how much of epithelium you're removing, because the machine decides how much of ablation is going to happen, and then based on that, it takes away the epithelium.
Try to remove 9 millimeter or 8.9.
Yeah.
You can't remove more than 40 or 30 microns of epithelium.
That is with the that is with the PTK mode. When you're doing a PTK PRK,
Even a Streamlight,
Yeah.
you can't do that. You can't remove that much amount.
in Streamlight you can't adjust the optical zone at all. You can't. It's a standard thing. You just have, the only thing which is adjustable is the epithelial thickness.
So,
I'm just talking of thickness.
yeah.
If you keep your optical zone
Yeah.
or epithelial remover around 9 millimeter, then you can't remove more than 30 or 40 micron of epithelium.
So you have to repeat, sir, you have to do a second treatment. You do one PTK treatment, then you do another treatment to remove the epithelium and then do the laser. I think we'll close.
Thank you very much. We have come to the end of our IC.